Hello, good morning, all. I welcome you all in the first class on benign bone tumors. As you all know, that bone tumors are a very important and essential part of orthopedics. And in an undergraduate level, you must be able to identify on X-ray what is a abnormality in the X-ray and what possible diagnosis it can be. So I hope you all know how to read a normal X-ray. And once you are able to read a normal X-ray, you would be able to better pinpoint what is abnormal X-ray. So whenever you find any abnormal growth or any abnormal shadow or any abnormal cystic or lytic lesion, the first thing that crops in your mind is whether it could be a benign tumor or it is a malignant tumor. Ultimately, you think of tumors. So from now on, in a few lectures, we'll see how to approach, how to differentiate, how to diagnose and how to treat bone tumors. Bone tumors can be very deceptive. They can be very easily confused with osteomyelitis, and hence osteomyelitis is always a very important differential diagnosis when you are treating bone tumors. There has been many confusion regarding the histogenesis and the nature of the tumors, mainly of aneurysmal bone cyst or fibrous dysplasia, and hence they are also included in bone tumors. Although in 1972, WHO evaluated a classification based upon histological criteria, particularly based on the type of differentiation showing tumor cells and the type of intercellular material they produce. However, Harlan and Alberto of Royal College of Medicine, Anderson Hospital, Houston, suggested a slightly variation in the WHO classification. But then, for your interest, is this broad classification where we divide it into first is bone forming tumors. These are the tumors which form extra bony tissue in or around the bone. Now, they can be benign or they can be malignant. Benign tumors include osteoma, osteoid osteoma, osteoblastoma. Malignant tumors include osteosarcoma that can further be juxtacortical osteosarcoma, or it can be periosteal reaction. It could be periosteal osteosarcoma, which is from the outside of the bone arising under the periosteum. Now, the tumors can also be cartilage forming tumors. These form more cartilage like cells. Again, they can be benign or they can be malignant. Benign can be chondroma, osteochondroma, chondromyxoid fibroma, or chondroblastoma, while malignant is chondrosarcoma. Now, there can be tumors that form with multiple giant cells, as they are called as giant cell tumor. This tumor was also earlier called as osteoclastoma, but now they are called as giant cell tumors. They can be classical benign type or they can be malignant GCT. They can be GCT in Paget's disease of facial bones. They can be GCT in long bones occurring in non-epiphyseal region. Or lastly, the fifth variety of GCT can be variants of GCT. There can be marrow tumors. Marrow tumors means the tumors that arise within the marrow. Most important is Ewing sarcoma. We all know occurs in children. Reticulosarcoma of bone, lymphosarcoma of bone, myeloma. Fifth is vascular tumor. Vascular tumor again can be benign or can be malignant. Benign can be hemangioma, lymphangioma, glomus tumor. Malignant tumor can be angiosarcoma. Sixth variety of tumors, when we classify, can be connective tissue tumors. They can be benign, either benign, mostly desmoplastic fibroma, or could be lipoma. In malignant variety, they can be fibrosarcoma or liposarcoma. Other tumors can be A. chordoma, B. adamantinoma, C. neurilemoma, and D. neurofibroma. There can be various lesions that actually are not tumor per se, but they appear like tumors and they behave like tumors. So they have been included in a variety called as tumor-like lesions. They can be A. solitary bone cyst, it can be aneurysmal bone cyst, it can be a simple ganglion, it can be non-ossifying fibroma, it can be fibrous dysplasia, it can be eosinophilic granuloma, it can be myositis ossificans, brown tumor of hyperparathyroidism. All these 8 variety of lesions, since they behave like tumors, have been included as tumors by WHO. Now, what we will try to learn is how to identify a tumor on X-ray. That means you have to know radiological features of various tumors. Benign, well circumscribed lesion. How do you identify a benign lesion? When you see a lesion which is well circumscribed, there is a narrow transition zone, and you don't find any periosteal reaction. And when the border is sclerotic, you think of a benign lesion. What do you understand by benign aggressive lesion? When new corticalization is seen, cortex seems to be expanded, cortex has thinned out. Usually these lesions are lytic. They may or may not have periosteal reaction, and they may or may not have a narrow zone of transition. These can be classified as benign aggressive. That means they are basically benign tumors, but their behavior is aggressive. Now, in purely malignant tumors, the third variety, the risky variety, which may be life-threatening, you see extremely great periosteal reaction. This tumor may be large, they may be permeative, that means they go through and through. And they may appear moth-eaten. So these are the various varieties of tumors what you see on the X-ray. Like this tumor, you see there is X-ray of the pelvis showing hip joint, and you can see a lytic lesion in the neck of femur, where you see it is a very well circumscribed. You can see clear borders. There is a very narrow zone of transition, and there is hardly any periosteal reaction. So this can be safely termed as a benign lesion. But here you see a benign lesion which looks to be aggressive because this looks to be circumscribed, narrow zone, almost narrow zone of transition, but it has a periosteal reaction. It has broken. It has a periosteal reaction. It is, the cortex is expanded, so it is a benign aggressive tumor. And the third variety, you find this X-ray is upside down, and you can find that this is a X-ray of a femur, of a knee joint. This is patella, this is femur, this is tibia. And you can find there is a periosteal reaction going posteriorly. There is a lytic bone. There is soft tissue expansion. This is a clearly a malignant lesion. There is no doubt about it. How do you uh, differentiate tumors based on the age of the patient? This is very interesting. Usually, osteogenic sarcoma and Ewing sarcoma are seen less than 20 years. Less than 40 years, you find giant cell tumor, chondrosarcoma, lymphomas, or METs. When it is around or more than 6, there can be METs. METs means metastasis, or it can be myeloma, or it can be chondrosarcoma, or it can also be fibrosarcoma. What are the identifiers on X-ray where you can just see by the tissue produced by the tumor should help you? When you see you have extra bone formation, calcification, sclerosis around tumor, you can think of osteoid producing tumor. When you can see popcorn lesion, arc ring calcification, this bright on T2 MRI and low on T1, that means the lesion is chondroid, that means cartilage producing tumor. But when the lesion is lytic, lytic means it is low on T2 and low on T1. That could be fibrous tumor. When the lesion is lytic and it is well circumscribed and it is bright on T2, it is dark on T1, that's a clear sign of a tumor with a cystic fluid. And when you find levels in the tumor, which is filled by fluid, you must think of aneurysmal bone cyst. Sites of tumors. If the tumor is seen in diaphysis, what variety of tumors it can be? It can be Ewing's, it can be osteoblastoma, it can be metastasis, it can be arabinopathy, it can be fibrosarcoma. If the tumor is epiphyseal, then the tumor can be chondroblastoma, it can be clear cell sarcoma, it can be giant cell tumor. But when the tumor is metaphyseal, then it can be either be osteosarcoma or it can be a bone cyst. Now, after having this brief introduction about the basic patterns of a tumor, we will try to learn individually each tumor, how it behaves, how to diagnose, how to treat. First of all, First of all is osteoma. An osteoma is a benign, uncommon lesion, slowly growing tumor occurring in the membranous bones of the skull and face. Usually seen in children and adolescents, and the site is usually frontal and facial bones. Externally, maybe intranasal, intraorbital. What are the signs and symptoms? They don't produce any symptoms usually. Intracranial osteomas may cause headache and epileptic seizures. Intraorbital may produce exophthalmos. In pathology, we see that osteomas are dense compact bone covered by fibrous tissue capsule, which is continuous with the periosteum. X-rays show osteoma composed of semicircle of extremely dense, sharply outlined, mature cortical bone. There is a little or no reactive bone formation. Prognosis. Once it reaches a certain size, it remains stationary and it does not undergo any malignant change usually. Treatment is excision only for diagnostic or cosmetic purpose, but actually, since it hardly ever gets malignant, there is no absolute indication to remove it. Second important benign tumor is osteoid osteoma. This is a benign osteoblastic tumor with a well-demarcated nidus of soft tissue, which is surrounded by a distinct reactive bone. Incidence is 2.6% of all the primary bone tumors is osteoid osteoma, which is a fairly common tumor. Usual age is 10 to 25 years. Usually males are involved with a ratio of 2:1. The site usually affected is tibia and femur, more commonly affected. Clinical features can be vague and intermittent pain, which is more at night. Pain is relieved by aspirin. There can be mild swelling, tenderness present at times. There can be vertebral scoliosis. Pathology. Vascular mesenchymal type of connective tissue stroma, where the proliferating fibroblasts and osteoblasts surrounds abundant pink staining osteoid tissue inside this tumor. You don't find a cartilage, you don't find any bone. What you find is vascular mesenchymal type of stroma with loss of fibroblasts and osteoblasts surrounding this pink staining osteoid tissue. So, other slide is where it shows that it has interlacing osteoid strands, vascularized fibrous stroma. So it has bone, it has fibrous but no cartilages. There can be prominent osteoblast and there can be prominent osteoclast. It is a slide showing these all are mesenchymal matrix. These are prominent osteoid tissue. These are osteoblasts. These are osteoclasts with multiple giant cells. Multiple nuclei. These are osteoclasts. This is osteoclast. This is osteoclast. This is osteoclast. So many osteoclasts can be seen. Many osteoblasts can be seen. This is osteoid tissue, and this is a fibrous mesenchymal, which is highly vascularized. You can see red blood cells, red. X-ray shows central lucency, which is surrounding the nidus with or without dense calcified center, but which is always surrounded by a reactive sclerosis. Now, what is the treatment? Wide en bloc dissection, with removal of the surrounding sclerotic bone. You have to remove the whole tissue, and the whole bone should be removed. What do you see in these X-rays? How do you read these X-rays? It is the X-ray of the pelvis with both hips, showing upper part of femur, both ilium, lower spine, sacrum. The patient presents with the pain in the right hip joint, and if you see X-ray shows sclerosis, inferior side of the neck, above grade lesser trochanter. On the X-ray, you are clearly able to find. On the CT scan, you can clearly find a lytic lesion on the inferior side of the neck, which is surrounded by a dense bone and nidus in between. In this X-ray, you can see a osteoblastoma on the lateral part of the upper part of the femur. There is dense sclerosis as compared to the other part. And in the CT scan, you can see there is a lytic lesion, which is osteoid osteoma. The same intraop. This is the lesion which has been removed. So that was osteoid osteoma. The other most common benign tumor is osteoblastoma. A benign osteoblastoma is an uncommon vascularized osteoid tumor which is very slow growing and characterized by absence of any abnormal periosteal perifocal bone formation. Incidence is 0.8% of all primary tumors. It was 2.8% of osteoblastoma, 0.8 of osteoblastoma. Age-wise, it is the same, 10 to 20 years. The common site is vertebra or flat bones usually. It is a well circumscribed tumor. When it is expanded, it is delimited by a shell of cortical new bone, dense sheets of osteoid and irregularly calcified new bone with intervening vascularized background of osteoblastic connective tissue stroma is seen. Giant cells may be present. Again, the typical classical features of a benign tumor is pain, swelling, but the pain is not as much of a fracture. On X-ray, you will find the lesion is well circumscribed, radiolucent, and expansile in fusiform fashion. Cortex is preserved with or without calcification. Malignant transformation has been reported. How to treat? When it is small to migrate, you can just cure it and bone graft. When it is small in the small bones, you have to dissect it. But when it is recurrent, it is happening even after dissection. In that case, you have to do a en bloc excision. There is no option otherwise. These are the few X-rays where you can see lytic lesion in upper part of humerus, lytic lesion well circumscribed in vertebra, in CT scan, and in flat small bones of metacarpal. You can find osteoblastoma. Third important tumor, benign tumor, is enchondroma. Enchondroma is a benign cartilaginous tumor. It is centrally located in the phalanx, maybe in the humerus. Incidence is more than osteoblastoma, that is 3% of all the bone primary tumors. It has a wide range of occurrence. It can be between 10 to 50 years. Usual site is metaphysis, and but it is common. It can be central. It can include whole of the phalanx. What is the pathology? The tumor is surrounded by a fibrous capsule. Neoplastic tissue is composed of bluish white translucent cartilage. Primitive mesenchymal cartilage is its periphery, while most mature is in the center of the tumor. So you know it is a cartilage forming tumor. And this cartilage appears bluish on the slide. The new forming cells, mesenchymal cells, are at the periphery, and the mature cartilage of the tumor is in the center. It can have normal appearing chondrocytes. The matrix is consisting of hyaline chondroid matrix. This is a bluish matrix, cartilage tumor. How do you diagnose it? It is usually diagnosed just by X-ray. There is pain and enlargement of the phalanx. The phalanx gets enlarged because so much of cartilage is being produced. The tumor may appear cystic, non-lobulated. Cortex gets thinned out and it is expanded. It may get perforated. No reactive bone formation. Circumscribed focus of popcorn-like density is a characteristic of chondroma. So, chondroma. So, if you find those lesions, popcorn-type lesion, you must think of chondroma. These are the popcorn-like cartilage lesions which help you to think of enchondroma. Here again, enchondroma. When it is in the pelvis, there are 25% chance that it can convert into malignancy. But in small bones, it usually does not convert into malignancy. How do you treat an enchondroma? Yes. When it is small, you have to just cure it and the wall is cauterized. But when it is large, you have to excise and with the removal of the capsule to prevent the recurrence. But when it is recurrent, you have to go for some radical resection. Other important benign tumor is osteochondroma. That was enchondroma. This is osteochondroma, which is also called as exostosis. Right? It is an aberrant development anomaly in the bone cartilage arising from the periphery of the cartilaginous growth plate. So you all know there is a cartilaginous growth plate between the epiphysis and the shaft. And it is abnormal growth at the periphery. It is the most important benign tumor. The incidence is 11% of all tumors. Hence, it is commonly seen in the growth period. Males are more affected in the ratio of 1.4:1. The most common site is tendinous attachments around the metaphysis of long bones in the region of knee, ankle, hip, and shoulder. In pathology, you usually find lateral outgrowth of cartilage having all the histological feature of epiphyseal plate in their cartilaginous cap. The interesting part is that it only continues to grow until the overall growth is happening. Once the growth ceases, the tumor also ceases to grow. On histology, you find a deep layer of periosteum, that is cambium. It has the ability to form cartilage and bone. Tumors may be due to perverted activity of this layer. So you can blame perversion of the activity of the deep layer of periosteum, that is cambium. What are the signs and symptoms? It has no symptoms. Pain and swelling can occur once bursitis is there, or due to pressure symptom, or there is malignant conversion in the tumor. Only then it becomes painful. It can be firm to hard. It is usually fixed, rather always fixed, painless mass overlying bone. The capsule usually is less than half centimeter, maybe thicker in children. You say you won't be able to. X-ray shows flow out from the cortex of metaphysis area to no reaction of underlying cartilage bone. Cartilaginous cap and overlying bursae are radiolucent. So this tumor on opening is much more bigger than what you see on the X-ray. 1 to 2% of osteochondromas can convert into malignancy. So what is the treatment? Remove cartilaginous cap, which is active part of the tumor. Extracapsular marginal excision, done in the majority of cases. And when there is recurrence, you have to really go for end block resection. These are the examples of osteochondromas. So, up till now, we have learned some basics of bone tumors, how to read the X-rays, how to classify them, and we have seen a few of the benign tumors. In the next class, we will take further remaining bone tumors. If you have any doubts, you can ask me now or afterwards. Thank you all.